Hello, let's talk about diabetes. I previously recorded this video and I just read the whole SDL out loud basically. And I got a text from my friend and he was watching this movie, Good Will Hunting. And he sent me a video of this one speech by Robin Williams when he's sitting with the main character on a park bench and he's talking to him. And the premise of the movie is that there's this kid played by who's it, Matt Damon? Yeah, and he's just a genius, and he's like this whiz. And the Robin Williams' character is sitting with him, and he's telling the guy, well, if I asked you about all these different things in life, you could tell me anything I wanted to hear about him, because you know all this stuff like Jeopardy, but you haven't been there, you haven't done any of this stuff, you're inexperienced. And at the end of the scene, I've got it pulled up here, and Robin Williams' guy goes, I can't learn anything from you that I can't read in some fucking book. And that quote really hit me, and it made me say, all right, well, I need to do something different with this text besides just read it out loud, because if all I'm doing is narrating what's going on here, I'm wasting my time and yours. So what can I tell you? Well, I can kind of tell you how to read this stuff. Diabetes, let's not do any exposition. Let's skip over type 1 for a bit. Let's go to type 2 diabetes, because that's where it can start to get a little confusing. And when I read this section about type 2 diabetes and all this and that about insulin resistance, what I really had to know is, why in the world do your cells develop insulin resistance? Why do you develop this concept of peripheral insulin resistance? And so did some more reading, figure out it's a protective mechanism, by which means a cell is going to downregulate the insulin receptors on its surface to protect itself from the hazardous side effects of having too much intracellular glucose. And because expression of the GLUT transporter, GLUT4 in peripheral tissues, that's coupled to the insulin signal. So if you take away insulin receptors, you're effectively pulling glucose transporters off of the surface of a cell. So you'll allow less glucose into the cell. And this is a really good thing for cells that already have a lot of glucose. So how do I know that? Well, it's later in the SDL. When you get this insulin resistance question, you skip down here, and this is where you'll get the answers for it. In this section called Pathogenesis of Diabetic Complications. This section might as well be titled, How Does Glucose Damage Cells? Because that's really what type 2 diabetes is about. First, you have too much glucose, and it's chronic, and it's sustained, and it's because you're eating too much, and you're also not moving around as much as you should, so you're not using glucose. So you've got persistently high glucose in the blood. That diffuses into cells. And once it's inside cells, it does some really bad things that cause cells to pull the insulin receptor off of their surface because they don't want any more glucose. And that's your insulin resistance. So everything that happens in the pancreas is subsequent to this section of the SDL that spells out how glucose damages cells. And it goes through three really big mechanisms. Number one, glucose forms these things called advanced glycation end products. And this is a non-enzymatic reaction. You don't need an enzyme, a separate protein, to take glucose and stick it onto some other protein. Glucose will just spontaneously adhere to certain amino acids. Specifically, if I were to guess, I'd probably say serine and threonine, because they have an alcohol and you can do a little condensation reaction and join them together. So when glucose plasters itself onto a protein, that protein plus glucose added on complex is called an advanced glycation end product, or an AGE. And so this is bad for a handful of reasons. Number one, that protein can't get rid of. It can't get got rid of. It can't get ubiquinated. So what that means is when it's time to recycle a protein and cut it up into its constituent amino acids, you can't do that because there's a glucose blocking the active site of the enzyme that's supposed to do that. And that's told to you right here at the bottom of page 11 when it says proteins that are cross-linked by these advanced glycation end products are resistant to proteolytic digestion. And this cross-linking of proteins is also extends to the basement membrane that anchors endothelial cells in place, lining capillaries. And so this protein cross-linking as a result of AGEs is what's going to lead to the characteristic thick basement membranes that you see in diabetic nephropathy. So this section of the SDL here at the bottom of page 11 tells you in words why you see this hyaline arteriolosclerosis, thick basement membrane, this diabetic nephropathy. What are you looking at here with this fuchsia-colored stain around all these cells? You're looking at a big, thick glomerular basement membrane. So why does it get thick? Because you get these AGEs that are just glycolated proteins, and they cross-link to one another, so you can't get rid of them. So you just throw down more protein on top of them, and the basement membrane gets nice and thick over time because you can't cut it up and get rid of it and remodel it. So that's at the bottom of page 11. And these advanced glycation end products also bind to a receptor, which is called RAGE, receptor for these AGEs. And that's expressed on the cell surface of inflammatory cells and endothelial cells, as well as vascular smooth muscle. So it's going to produce pro-inflammatory effects from these inflammatory cells when it binds to this RAGE receptor. It's also going to make reactive oxygen species from endothelial cells, and it's going to induce proliferation of vascular smooth muscle cells and synthesis of extracellular matrix, so you lose your vasomodulation, your ability to constrict and dilate accordingly. So that's what leads to blood vessel damage and diabetes. Your endothelial cells get really mad and angry because of these advanced glycation end products, which hemoglobin A1C is an example. It's just a protein, which is just a sequence of amino acids, you know, and you got some hairpin loops and some beta sheets, right? It's just a protein like that, and you just so happen to get glucose stuck onto the side of that protein. It's just protein plus glucose for all my visual people. So that's one of 3 different things that really hurts a cell when too much glucose gets inside of it. That's the meat of this SDL. What's another thing? Protein kinase C. Activation of protein kinase C. High glucose is going to contribute to the activation of PKC, which goes on to enact some endothelial specific effects. And so diabetes is going to give you this micro or macro angiopathy. It hurts your blood vessels first. And this PKC pathway is a big reason why. You get a lot of VEGF going, which means that cells are going to be dividing and you're going to be growing new capillaries. You get decreased nitric oxide levels, which is that impaired autoregulation. So that's a vasodilator, and you want to be able to vasodilate when a lot of blood comes through a capillary to accommodate it. Because if you stay constricted, well, then all that force of blood might pop the capillary open. That's an aneurysm, hence diabetic retinopathy. And then due to this protein kinase C, you'll also see a lot of TGF beta, transforming growth factor beta. And when you think that, you need to think collagen, like Pavlov's dog, TGF beta, extracellular matrix, fibrosis. It's your wound healing cytokine. It's going to shift macrophages from M1 to M2, right? And M2 macrophages do the long-term healing response. So that's TGF beta. So again, more fibrosis around these small blood vessels, less autoregulation, means they stay closed, but then you force a lot of blood through, maybe you're exercising or something, and the thing just goes pop because it can't dilate properly. And then the third thing that glucose does that is really bad for cells, the insides of cells, is in certain tissues, glucose gets converted to sorbitol by this enzyme Aldose Reductase. And friends, I am going to tell you, this is probably the most important part of this SDL, because if you understand this enzyme and where it's at, you get diabetes. You just do. You get type 2 diabetes. So this enzyme, Aldose Reductase, is localized to some very particular tissues, and it's right here in the SDL. You find Aldose Reductase in your nerves, in your eyes, in your kidneys, and in your blood vessels. So tell me, what organ systems are affected in type 2 diabetes? You get a neuropathy, you get a retinopathy, you get a nephropathy, and you get some microvascular damage. There it is. And wouldn't you know that these are the only organ systems, the only tissues that express this aldose reductase enzyme. So what does it do? Great question. Aldose reductase plays with glucose. So in diabetes, you got too much glucose. You got to do something with it, right? Because eventually you throw it down, what's that called? Glycolysis? I'm dead. I can't remember that first metabolic pathway. Oh man, I was on a roll. You throw it down, you make some acetyl-CoA, whatever that thing's called, I forget. And then you throw it through the Krebs cycle and you make a whole lot of NADH and FADH2 out of it, right? And you spin those off the electron transport chain. But eventually, you make so much ATP that you're just going to feedback inhibit all of your metabolism because you don't need any more energy. So when that happens, you've got all this glucose in the cell. You've got excess glucose. You got to do something with it. What do you do with it? Well, if you are a cell in the eyes or the kidneys or the peripheral nerves, you can take glucose and spin it through aldose reductase to make sorbitol. And that's the worst thing you could ever do with glucose. Let me tell you why. First, this enzyme is unidirectional. You don't make glucose from sorbitol. Even if you could, you wouldn't use the glucose. But sorbitol is stuck as sorbitol. The only thing that sorbitol can do is become fructose. And we know from learning about the liver, fructose is no good for you. What can fructose do? Only thing that can do is go to the pentose phosphate pathway, maybe, but usually it's going to get thrown to glyceraldehyde and glycerol, and it's going to make the backbone for triacylglycerides. So it's going to go to fatty acid synthesis, essentially. That's no good. You don't want those accumulating in any cells, really, not too much of them. So that's where sorbitol goes, but also in the long time while sorbitol is waiting to become fructose, it's just sitting around. And let me tell you, it's sitting around inside the cell because you don't have a transport protein that can pump sorbitol out. Once it's in the cell and it's stuck in the cell. So why is that a bad thing? Well, because water follows solute. And a lot of sorbitol that you're not doing anything with is just going to pull water into the cell and make it swell up and create an osmotic stress on that cell. So if you're a Schwann cell or a parasite around a retinal capillary, do you want to be expanding and be metabolically stressed like that and even threatened with lysis if too much water gets inside of you? No. Because then if you start popping your Schwann cells, well, you start demyelinating nerves, and there's your diabetic neuropathy, right? And then if you start popping the cells that control vasoconstriction in the capillaries in your eyes, well, then there's your aneurysms, and there's your diabetic retinopathy, right? So it's because of this sorbitol molecule. It can't get out of the cell, so it pulls water into it. And just to add insult to injury, when glucose is turned into sorbitol, it has the nerve to use up one molecule of NADPH in order to turn it into this useless sorbitol. And that's no good either, because you understand that you need NADPH to replenish glutathione whenever it quenches a free radical. So the less NADPH you have, because you're spending it all on sorbitol, the less that you can spend on quenching free radical damage floating around in the cell. So not only do you get the osmotic stress, not only do you get the fructose, which is going to go straight to fat, you also get oxidative stress from the low NADPH, which makes you unable to replenish glutathione. So the theme of all this is that the cells that express aldose reductase, this one enzyme, are particularly vulnerable to even more oxidative stress than any other part of the body, because this enzyme takes glucose, of which there is a lot in diabetes, and turns it into sorbitol, which is useless. So those are the three big ways that this SDL tells you high glucose really damages cells. So let's take it back to the top. Type 1 diabetes, everything we just talked about really doesn't matter because you don't have any insulin. Well, actually does matter because you're going to give these patients exogenous insulin. So then they're going to get all that high glucose pushed into their cells. And so whether you're type 1 or type 2 diabetes, the three things we just talked about, ages, protein kinase C, sorbitol, because Aldose Reductase, all three of those mechanisms are the source of cellular damage in hyperglycemia. So for both type 1 and type 2 diabetes. Now, after cells get damaged, then they're going to start down-regulating their insulin receptor. Why? Because they don't want any more glucose. So that's where we really get into type 2 diabetes. Once you down-regulate that insulin receptor, your pancreas sees a high blood glucose and it won't stop making insulin. Why won't it stop making insulin? Well, because remember that your pancreas has this potassium export channel that's always open, but ATP inhibits this potassium channel to depolarize the cell due to the accumulation of intracellular cations, which is going to allow calcium in, which facilitates the binding of insulin-containing vesicles to the cytoplasmic side of the cell membrane that's going to pop that insulin out into the blood. So as long as you have ATP, aka glucose in the pancreas, you're going to be making insulin. So as insulin resistance goes up peripherally, meaning as less and less and less and less insulin receptors are expressed on the surface of these cells, that just means there's more glucose left in the blood for the pancreas to see. And so the pancreatic response to that is to keep making even more insulin. And so that's the middle section of this trifoil graph here, is to show you beta cell hypertrophy in response to peripheral insulin resistance. Now, this is a really good time to point out to you that when your beta cells have hypertrophied, but they have not yet failed, we are technically going to call that prediabetes. And the good news about that is that prediabetes is somewhat reversible. With the proper dietary and lifestyle modifications, you can get this beta cell hypertrophy to just turn right around and go back to a normal pancreas. But the thing is, it's really hard because all your peripheral tissues have downregulated that insulin receptor. So what that means is if you're trying to reverse prediabetes and go back to normal rather than continue going on to diabetes, you really need to get your blood sugar down. And as we'll take a look at in a bit, you need to get your fat mass down too, because adiposity interacts with insulin in kind of a positive feedback manner that kind of fuels the generation of insulin resistance as well as the creation of more lipids. So that's prediabetes. And then once your beta cells of your pancreas start failing, that is when we are going to officially call it type 2 diabetes mellitus. So that's your pancreatic response to insulin resistance. I would like to take a moment. This is a slide from pharmacology, a really good slide because this slide made me connect the dots in my mind to say, oh, insulin resistance is literally every tissue in the body. It's not just your liver and your fat and your muscle, because I was thinking about it real narrow-mindedly. But then I saw this slide. We started talking about the kidneys, and I was like, oh, your kidneys also respond to insulin, and they can get insulin resistant too. So that would be a really bad thing that would just propagate the problem. So here's how it works in the kidneys. Normally, insulin is only going to be in the bloodstream when there's a lot of glucose in the bloodstream. So insulin is going to tell your kidneys, specifically tubular cells of the proximal convoluted tubule, that they need to excrete glucose. We need glucose out of the body. And so in order to do that, we're going to downregulate, type that wrong, we're going to downregulate the sodium glucose cotransporter because we don't want to pull any more glucose back into the body when we're already hyperglycemic. So that's what insulin tells your kidneys to do, pee out glucose. So imagine now, you're a type 1 diabetic. You don't have any insulin. You're hyperglycemic. But because you don't have the insulin signal, your kidneys are going to think that you need to hold on to glucose. So it's going to inappropriately upregulate SGLT and hold on to glucose. Diabetes type 2. you've got insulin resistance. That means that inside the epithelial cells of your kidney, glucose concentration is so high that they don't want any more. They can't take any more. So how does a cell respond to high glucose? Because that's damaging. It downregulates the insulin receptor. So when your kidney, your cells of your kidney start downregulating the insulin receptor, what that means is that when you've got hyperglycemia and a lot of insulin in the blood, your kidneys aren't going to see that insulin, and so they will inappropriately put glucose back in the body because they think you need it, because they don't see the insulin. So that's why we can treat diabetes with, amongst many drugs, one of them is the SGLT2 inhibitors, which are going to act on this channel in the kidney and block it up, because when you're insulin resistant, it's inappropriately overactive. Now let's discuss a little bit of glucose insulin resistance in other tissues. Now, insulin is an anabolic hormone. It's the anabolic hormone. It builds stuff. A, B, C, D. Anabolism builds, catabolism destroys. So anytime you got insulin, you got an anabolic signal. That means that muscles are going to be making protein. And that means that fat is going to be synthesizing triglycerides. And that means the liver is going to be making glycogen. So let's walk through this. Insulin resistance. Why do you get it? You get it because blood glucose is constantly too high, and we know that there are damaging cellular effects of too high glucose, and so individual cells downregulate the insulin receptor so that they don't have to eat any more glucose because they don't want it. So when you downregulate the insulin receptor, what does that look like in these target tissues? Well, your skeletal muscle is not going to take up glucose from the blood. That's kind of bad in the setting of hyperglycemia because you got to get it out of your blood somehow, otherwise it'll be persistently elevated. And then inside the myocyte, you're going to be degrading proteins, because without the anabolic insulin signal, you'll be in a catabolic state, and that means you'll be breaking things down to get energy out of them. And one of the things you get energy from is alanine, which you can send to the liver to do some gluconeogenesis. Now, your liver, we said when the insulin anabolic signal is there, it's going to make a lot of glycogen. But when your liver pulls the insulin receptor off its surface because it doesn't want any more glucose, what's going to happen is eventually the liver shifts into a catabolic state in which it starts breaking down glycogen. That's glycogenolysis. And when it runs out of glycogen, although there's a lot of glucose in the blood, because it's not getting the insulin signal because of its downregulated receptors, the liver is going to do gluconeogenesis, and it's going to be fed with the alanine and the lactate sent to it through the bloodstream by skeletal muscle. So you've got inappropriate gluconeogenesis, which is just making this pervasive hyperglycemia even worse. And then finally, in adiposity, what does insulin resistance look like? Well, normally insulin, this anabolic hormone, is going to make fat cells grow bigger and store more triglycerides. And incidentally, insulin upregulates this lipoprotein lipase enzyme, which is responsible for pulling free fatty acids from lipoproteins into adipocytes, into fat cells. So when you have insulin, you're putting fat into your fat cells. But when you don't have any insulin, or when you're insulin resistant, you're not going to be expressing this lipoprotein lipase enzyme. And so number one, lipoproteins stay in your blood, and triglycerides and free fatty acids too. And then number two, the fat cells that are eating all of those lipoproteins in their products, they're going to start breaking down their own fatty acids because they're in a catabolic state because they're insensitive to insulin. So that's why you're going to see high blood lipids in a diabetic patient. So that's the effects of insulin resistance on a variety of target tissues. Let's take a look now at what was also a tough egg for me to crack. How does adiposity interact with insulin? So first of all, you get these excess intracellular non-esterified fatty acids. You get them in the bloodstream and then they diffuse into cells. And these non-esterified fatty acids are really bad because you have to use them immediately. Why? Well, recall that when you esterify a lipid, you make it amphipathic to where it's partially hydrophilic on one side because you just plug an oxygen onto one of the terminal carbons of that lipid, and so that oxygen can play relatively nice with water. And it can also couple a free lipid to some other lipid, maybe on a glycerol backbone, and you can store that lipid when it's esterified. And also recall that lipids really don't travel in the bloodstream unless they are esterified. And in fact, esterification is kind of the doorway for a lipid to go from a cell to a lipoprotein. If you want to package it into a spherical lipoprotein and send it down its way in the bloodstream, you have to esterify a lipid first in some means to store it. So, non-esterified fatty acids, if they're floating around in the bloodstream, you know something has gone wrong somewhere. I wish I could tell you more about how you get these non-esterified fatty acids, but what the SDL really touches upon are the consequences. Too much diacylglycerol, which is a signaling molecule that can trigger the protein kinase C pathway, which is something we talked about earlier, and also ceramide. That's a phospholipid, and that's all I got to say about that. So you just don't want these non-esterified fatty acids inside the cell because they're going to mess up your insulin response and lead to even greater insulin resistance. Attenuate, what does that word mean? Reduce, yes, more insulin resistance. It attenuates insulin signaling. Adipokines, all right. This is a functionally useless part of this SDL, but I'm going to talk about it anyways because I've read this like 3 times and I'm like, what are these, yo? And so long story short, you will never get asked a test question about this, but short story long, adipose makes some good hormones. Adiposity is hormonogenic, meaning it makes these molecules that signal different messages to different target tissues. And the classical example of that is going to be leptin, which is your I'm full, I need to stop eating hormone. Fat cells make that. They also make these things called adipokines. So there are some good adipokines and some bad adipokines. Total adiponectin levels are reduced in obesity. And adiponectin is an anti-hyperglycemic adipokine. So it's a good adipokine, especially when you've got diabetes. But the more pudge you got, the less adiponectin you have. So the less controlled your hyperglycemia is as a result. And then finally, adiposity does secrete our run-of-the-mill pro-inflammatory cytokines, TNF-alpha and interleukin-6. Real bad dudes. We don't like either of them. They're both wanted for multiple crimes in the state of the human body. And so the more adipose you have, the more TNF and IL-6 you have floating around in response to any given stimulus that can activate a stress response. And recall, inflammation puts you in a catabolic state. De facto, period. You need to use energy because your immune system is metabolically expensive. I mean, you've got these cells that are moving all over the place. You know, it's like you got a football field full of players, you know, and they're just running. They're sprinting and throwing and diving and catching and blocking. That's your immune system compared to like the rest of your body, which is like, I don't know, the field, the turf, the stadium, you know, it's like inert and immobile compared to these immune cells running around out here. So that uses ATP and energy. So you pull energy from the rest of your body in order to fuel your immune system in such a time. That's why you're catabolic. And so that's the opposite of what insulin does. So it makes you even more insulin resistant when you're infected or under a general inflammatory stress response, which is why managing dietary inflammation is so important for diabetics. So this is what you see on histology of type 2 diabetes. You see a bunch of amyloid. Do you see any lymphocytes? Me neither. And go up to type 1. Do you see any lymphocytes? Yeah, I see a few. Lots of them all over here. Now, don't mistake these eosinophilic cells for amyloid. Just don't. That's amyloid. It's anuclear. Check. Okay, gestational diabetes. What I have to say about this is that if you have a patient who has type 1 or type 2 diabetes and then they become pregnant, that is not gestational diabetes. Gestational diabetes is, I didn't have diabetes. I became pregnant. I got diabetes late in my pregnancy. I delivered and it kind of went away. That's gestational diabetes. So these patients are at an increased risk for type 2 diabetes later on in life. I feel like we could have had more than a couple paragraphs on this, because now I'm wondering, well, macrosomia, yeah, check. That makes sense for the neonate, you know, because mom's got a lot of insulin and insulin's anabolic. So baby's just sitting in mom's belly looking like Arnold Schwarzenegger. Check. Hypoglycemia, that kind of also makes sense, because if baby's got a lot of circulating insulin when they're born, well, then that insulin pushes glucose into cells. So hypoglycemia makes sense. But then polycythemia, what, yo? And then hypocalcemia, I'm like, where's that coming from? And maybe they're in some sort of acidosis, because recall that calcium binds albumin, but protons also bind albumin. But no, that wouldn't make sense either, because then an alkalosis gives you hypocalcemia. So I got no clue what's going on there with the hypocalcemia. If somebody can enlighten me, I'd love that. That's really the important stuff in this STL. All the tissue damage that you ever see in diabetes, be it the eye, the kidneys, or the nerves, is going to be due to glucose, due to those three pathways we started off with. Remember that enzyme aldose reductase. Remember that it's really only found in the eyes and the nerves and the kidneys, and that explains the tissue level finding of diabetes. From page 9 here, I think it's really important to point out blurred vision for the purpose of your practice forevermore. You know, if a patient comes in and they've gotten their prescription bumped up like 2 or 3 times in the past year, then you ought to be suspecting some sort of glycemic abnormality. You ought to be getting them screened for prediabetes, type 2 diabetes, because glucose will get into the lens of the eye, which is normally a pretty acellular structure, recall, but glucose can diffuse through cells into the lens of the eye, and recall, water follows glucose. So water is going to go into the lens, and that's going to expand the lens and push it out, making it more convex and increasing its refractive index. And so what that means is that, well, your eye muscles are going to be looking at something, and your ciliary muscles are going to be pulling on your lens in a manner that your brain thinks is appropriate, but then your lens itself is going to have some sort of problem with it. It's going to be too curved. Why? Because all the glucose got in there and brought water into it. So that's blurry vision right there. You're going to be projecting an image onto a spot in your retina that you shouldn't be projecting it onto. So again, blurry vision. Yeah. Remember that C-peptide, if you see C-peptide in the blood, that means that the person's pancreas is making insulin. If you don't see any C-peptide, they're a type 1 diabetic. So that test is most useful when you get like the teenager or the early 20s in there, and you can't really tell off the bat if it's type 1 or type 2, so you get the C-peptide, and that gives you the answer. Blurry vision included in classic symptoms, because again, like polyuria makes so much sense. You got a lot of glucose in the urine, but then a lot of things give you polyuria. So if they give you polyuria plus blurry vision, it's like, whoa, slow down there, diabetes. Your diagnosis, all that I really want to say here is that you're definitely going to get these tests twice. you're not going to make diagnosis based on one fasting plasma glucose. Only exception to that being your HbA1c, which you're not going to go ahead and get another one right then because, you know, it's indicative of a roughly 3-month period of time, so it won't change that much if you order one the very next week. Hypoglycemia, how does it present? Sympathetic overactivation. What's a good initial treatment? A beta blocker to slow down the tachycardia, palpitations. Diabetic ketoacidosis. What are the keto acids? Beta hydroxybutyrate and acetoacetic acid, and beta hydroxybutyrate, the predominant form in blood. And so it's just this little like 5-carbon or so structure with a couple of OHs on the end. And so one of those OHs can just abstract a proton and pick up a negative charge. And so that's why it's a keto acid. It's acidic, you know. And this is going to float around in the bloodstream and contribute to lowering the pH when it pops that proton off, because the proton is what lowers the pH and makes the blood more acidic. And so that's why this is called ketoacidosis. And so is this going to be gapped or ungapped? It's going to be gapped. Metabolic acidosis, because anytime you have a gapped acidosis, what that means is that you've got some organic acid inside the bloodstream that's not bicarb. Talked about this section. This is it. If you understand the section titled Pathogenesis of Complications, you understand this whole SDL. So after we talk about how glucose damages cells, then the SDL transitions into talking about how does glucose damage tissues. That's what this section should be named. Pathology of diabetic complications, talking about systemic complications, entire organ systems. So number one, you get endothelial dysfunction. Remember, you're going to get this protein kinase C that's going to give you poor autoregulation of your blood vessels, and you're also going to see cell swelling due to this aldose reductase enzyme, and you're going to see these ages to non-enzymatic glycation, and so that's going to get in your endothelial cells and mess them up. So that can present just about any organ. Hyaline arteriolosclerosis, however, you're going to see particularly in the brain and in the kidneys due to diabetic damage. And there's one other thing that can cause hyaline arteriolosclerosis, and that's hypertension. So if you have a diabetic hypertensive, you can bet their whole kidney is going to look like this Jake right here does. Diabetic microangiopathy is barely different than hyaline arteriolosclerosis. What the microangiopathy is really referring to is diffuse thickening of basement membranes that's going to present, again, predominantly in the kidneys as this diffuse mesangial sclerosis thickening. And those are kind of, again, these are kind of global vascular complications. Now we get into specific symptoms. We got diabetic nephropathy. GBM thickening, because those ages, those glycated proteins are cross-linking everything, and so you can't get rid of old basement membrane. And then diffuse mesangial sclerosis, which is associated with the overall thickening of the GBM. So again, basically the same thing, just be able to correlate both these phrases with diabetes, because, you know, I mean, they look like answer choices to me. And then you see a nodular glomerulosclerosis, which could be called Kimmel-Steele-Wilson nodules, and they're PAS positive. And they originate in the mesangium, one more time. They're mesangial lesions that are just thickening of the basement membrane. That's your diabetic nephropathy. One last important point. In diabetes, you're going to see efferent arteriolosclerosis. That means that the walls of the efferent artery are going to thicken. That's really bad, because you need to be able to play with your efferent with angiotensin II, right? So you can control your GFR. And if your efferent is stuck, well, then that means that your GFR is stuck on high, because if you clamp the efferent afferent's wide open, well, then Gosh, that's such a high pressure glomerulus. All your blood is going to go down into your tubule. GFR goes through the roof. So this efferent arteriolosclerosis, number one, diabetes is like one of the only things that is going to give this to you. Number two, efferent arteriolosclerosis, I heard from Golyan, precedes afferent arteriolosclerosis by about a decade or so. So number three, because it's particular to the efferent arterial, what does that mean? It means we can treat it with ACE inhibitors, lisinopril, yes, check. That's going to clean this dude right up. That's going to dilate it, and you're going to get blood sugar under control, and you're going to exercise, and you're not going to have any more kidney problems ever, basically. Now we talk about diabetic retinopathy. I'm going to review some photos of this just because it's been a while since we touched on it. Understand that the pericyte is the cell that's really most affected by excess glucose, and that's going to be the regulatory cell responsible for vasomodulation, so constriction and dilation and general leakiness of any capillary in the eye. And you've got a lot of small capillaries in the eye, so these retinal pericytes are important. And as soon as you lose them due to osmotic hyperglycemic damage, then you start to get fibrosis, which predisposes you to retinal artery aneurysms. And then you get some hemorrhages, and that's going to lead to an immune response when they're going to clean that up, and it's going to be called cotton wool spots. Actually, it's going to be called granules. And then after you have a few more hemorrhages, the blood reaches the nerve fiber layer of the retina. That's called cotton wool spots. So looking at diabetic retinopathy, first thing that happens is that look at how thick this endothelial cell is in the setting of diabetes compared to this endothelium that has normoglycemia. You notice that this cell is big and thick, and that's because of the accumulation of intracellular advanced glycation end products. They just stick around. They can't get degraded or ubiquinated, and so they just collect trash up inside the cell. This here on top, this is a pericyte, right? And then this dude here on the bottom is going to be an endothelial cell that pericytes wrapping around it. And then over here, normal pericyte, normal endothelial. Yeah, way more swollen in diabetes. So after enough damage, eventually one capillary just goes pop, and you get a hemorrhage, and they're flame hemorrhages on fundoscopy. Here's what they look like on the right. Here's the histology on the left. You can tell it's bright ruby red in these areas where there's been a lot of blood leaking out of a capillary. And so after the blood leaks out of a capillary, well, you send in immune cells to clean it up. So you send in a few neutrophils for like 24 hours, and then you send in a lot of macrophages. And when macrophages get in there, they just munch everything up, and that's how you get these hard exudates, dense exudates, and they're just lipid-laden macrophages that have cleaned up the debris of the old hemorrhage, and you'll see them on histology too. And so then, because that area is weakened and predisposed to further damage, it can happen again and again and again, and infarctions are going to move from this photoreceptor layer kind of outwards until they reach the nerve layer on top. And so then when they reach the nerve layer, a lot of edema pools there. And that's what we call these cotton wool spots. And that's diabetic retinopathy recapped. Here's a paper I threw in there, just the empirical proof that if you non-enzymatically glycate a bunch of proteins, they don't go away. No protease that you have is capable of cutting them up. Or they can, but it's way slower. And so then diabetic neuropathy, same thing is going on here. A lot of glucose gets into nerve cells, specifically Schwann cells, and then it causes osmotic damage. These things swell and they pop because of the oxidative stress and the osmotic stress. And when they pop, well, then you've got a bunch of demyelinated nerves, and so patients present with numbness, tingling, and possibly aesthesia, loss of sensation, typically distally, symmetric, and ascending slowly. So a distal symmetric polyneuropathy means, what's the prototype? Both feet are numb. And a good physical exam test to remember is take their ankle and you tap the back of it with a reflex hammer, and you got your palm under their ankle. And so when you tap it with the hammer, they should plantar flex, because your gastrocnemius and soleus, that's your Achilles tendon essentially is that gastrocnemius. So that should contract, and when it does, your toes should go to the floor, plantar flexion. And so if you're tapping and dude's foot is like going up instead, you're like, oh, whoa, you've got some sort of neuropathy down there because you're not mediating that reflex properly. And you could not only get a somatic neuropathy, you could get an autonomic neuropathy as well, and you're going to recognize that on a question stem pretty handily. You know, it'll be maybe like dysmotility of the sigmoid colon, constipation. Maybe you're going to have a neurogenic bladder and trouble voiding. And sympathetic, parasympathetic diabetes makes no discrimination. It's kind of like rolling the dice. You don't know what nerves are going to get hit. You just know that nerves are predisposed to getting hit. So, I mean, this could get really, really bad, even if it were the vagus nerve that got a neuropathy with it. Then you could get disinhibition of the parasympathetic tone to the heart, you know, so no parasympathetic, you're just stuck on, so you can have a resting tachycardia if you're not throwing any vagal activity at that SA node. So yeah, you're gonna recognize that. And then finally, anyone who's still with me who's like, yeah, I'm gonna be a surgeon, you need to know everything about diabetics too, because diabetes with the neuropathy, foot injuries, very, 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 very common, very common. And so you might get consulted, hey, should we amputate this toe? Should we amputate this foot? Where should we amputate? You know, and so it's like, that's a case that you very well might get dragged into one day. And so understanding the pathogenesis of diabetes is going to equip you to be verbose in that consultation. That's about all I got. Thanks so much.